HSM 801, page 418. Sample research. Impact of the health system on health indices. Thesis. Framework. Health system building blocks, SBBs, and health indices. Theory. Building blocks are interconnected and important for effective delivery of health outcomes. Design. Correlational. Model. Predictive, that is, predicting an outcome based on specific inputs. Hypothesis. Existence of relationships between the SBBs, system building blocks, and population health indices. Analysis. Pearson's correlation, multivariate statistical analysis, and partial outcome measures. Effect size. Pearson's R, small, is equal to 0.1 to 0.3 or minus 0.1 to minus 0.3. Medium is equal to 0.3 to 0.5 or minus 0.3 to minus 0.5. Large is equal to 0.5 or greater or minus 0.5 or less. Thesis statement. SBB inputs, indices, outcomes. Inputs, you have 6 inputs, right? Yes, 6 inputs. 1, 2, 3, 4, 5, 6. Leadership / governance. 1, 2. Healthcare financing. 3. Health workforce. 4. Medical products infrastructure. 5. Information and research. 6. Service delivery. So all of them move at different levels to indices, outcomes. Indices, you have health indices, e.g. mortality and morbidity statistics. Indicators and models. Parameter, indicator. Health outcome, number 1 parameter. Under indicators, you have maternal mortality ratio per 100,000 live births, under 5 mortality ratio per 1,000 live births, neonatal mortality ratio per 1,000 live births, life expectancy at birth in years, healthy life expectancy at birth in years. Leadership governance / governance, that is number 2 parameter. Indicator, regulatory core capacity bracket score. Number 3 parameter, healthcare financing. Indicator, universal health coverage service coverage index, UHC SCI. Number 4 parameter, health workforce. Under that indicator, you have density of doctors, density of nurses. Number 5 parameter, health commodity and infrastructure. Under indicator, you have FP, family planning needs met. Number 6 parameter, information and research. Under indicator, you have official development assistance to research and system. Number 7 parameter, service delivery. Under that indicator, you have skilled personnel during ANC, that's antenatal care and delivery, bracket percentage. So page 422, this compares Nigeria and comparable countries, WHS 2021. So it compares Nigeria and some other African countries, basically. Maternal mortality ratio, MMR, under 5 maternal MR, IMR, DPT 3, life expectancy at birth, SBA, UHCSS. So it compares a lot of countries, and okay, so Nigeria's one is highlighted. Data on SBB, independent variables. So region, met needs for FP, UHC, SSC, per capita research and support, HS support, density of doctors, density of nurses and midwives, regulatory capacity, SBA. So region, that's WHO regions. You have Afro, AMRO, CRO, Euro, EMRO, WPRO, then global. Afro is Africa, AMRO is okay, so that's that. Health outcomes, page 424. Health outcomes, dependent variables. So you have for the regions again, you have MMR, life expectancy at birth, healthy life expectancy at birth. You have under 5 MR, NMR, that is neonatal. You have the regions as well: Afro, AMRO, CRO, Euro, EMRO, WPRO, global. 425, page 425, scatter plot. UHC, that is universal health coverage effect on MMR, U5M under 5 mortality, life expectancy, and then DPT 3. Effects of HS health system on MMR, regional statistics from WHS 2021. So you have parameter, you have indicator, you have Pearson correlation, you have p-value, you have model summary. This is page 426. So under parameters, you have leadership / governance, number 1, indicator, regulatory capacity, you have Pearson correlation, p-value. Okay, so for parameter number 2, healthcare financing, universal health, UHC service coverage index, UHC SCI, Pearson correlation, p-value. Third one, health workforce. The indicators are density of doctors, density of nurses and midwives. Number 4 parameter, health commodity. Indicators, met needs for modern family planning. Number 5, information of parameter, information and research. Indicator, ODA to research and HS support. Number 6 parameter, service delivery. Indicator, skilled personnel during ANC and birth. So for each of these, you have Pearson correlation, R, p-value, Then there's general model summary. This is page 426. Effects of HS on under 5 mortality regional statistics in WHS 2021. So you have HS building block indicator, Pearson correlation, p-value model summary, page 427. So you still have under HS building block 1 leadership / governance indicator, regulatory capacity. 2 HS building block healthcare financing indicator, UHC service coverage index, UHC SCI. Number 3 health system building block, health workforce. Under indicator for that you have density of doctors, density of nurses and midwives. Health system building block number 4 health commodity. Under indicator you have met needs for modern family planning. Health system building block in number 5 information and research indicator, ODA to research and HS support. HS building block number 6 service delivery indicator, skilled personnel during ANC and birth. Okay, so still the same thing on this page 428, the same HS building block as repeated earlier. Okay, so they're basically the same thing. 428, just that under the model summary there are some differences. R square adjusted, R adjusted. So I think you may just look at them. 427, 428, even 429, 430. Okay, so page 431 now. What the data mean? The HS building blocks explain greater than 90% of the variance in health indices globally. All building blocks had large effects on health indices. Greatest impacts on health indices: 1. MMR, system governance and service delivery. 2. U5MR, governance, UHC and service delivery. 3. NMR, that is neonatal, UHC and service delivery. 4. Life expectancy at birth, that's service delivery, UHC and governance. 5. Healthy life expectancy at birth, UHC and service delivery. So research versus program evaluation. So component evaluation, research. Component number 1, primary purpose evaluation, to improve practice or service delivery in an organization or setting, to justify the need to continue, eliminate or modify a program, to inform decisions about future programming. Research, to generate new knowledge or test hypotheses. Component number 2, scope / generalizability evaluation, focus on a particular program or aspect of a program. Results are not intended to be generalizable beyond study sites. Research aims to be generalizable to other individual situations, settings. Scientific generalizability guides the project design and includes precise and defensible techniques for sampling, data collection, and analysis. Component number 3, primary audience evaluation, the organization, institution, or system that is being evaluated. Others may have interest in the results or process but are not the primary target audience. Research, primarily scholars, practitioners, or organizations well beyond the ones comprising the immediate affiliation of the researcher and or participants. Component number 4, design evaluation, relies on systematic data collection. Program objectives and evaluation questions drive the design. Key stakeholders often influence the questions. Research relies on systematic data collection, well-controlled scientific framework designed to produce generalizable results. Component number 5, benefits evaluation. Participants may benefit from findings produced through improved services or service delivery, can change practice in the local setting immediately. Research may not benefit the actual research participants. The knowledge is intended to have future benefits for smaller individuals as well as benefits for those who wish to apply the research findings and or theory developed. The time frame for benefits can be long. Component number 6, results evaluation. Answer the evaluation questions. Primary intent is for use by the program or organization itself. Sharing results more broadly is a secondary benefit. Research. Answer the research question. Made widely available for use by others via presentation or scientific publication. Conclusion. Research in health can be health research, health services research, and health system research. Critical to conduct research to answer questions or solve problems. Research follows systematic and rigorous approach to enhance reliability and validity. Understanding the research process is critical to conduct of effective research. Page 435, health system strengthening. Health system strengthening / reform, HSR. HSS that is health system strengthening, is an array of initiatives that improves one or more of the functions of the health system and that leads to better health coverage, and that leads to better health through improvement in access, coverage, quality, or efficiency. WHO. HSR, that is Health System Strength Reform, is an ongoing process of sustained, purposeful, and strategic change in policy and institutional arrangements in the health sector, designed to improve the performance of the health sector and ultimately the health status of the population. Basic tenet of reform system thinking. Systems can be primarily mechanical or adaptive. Mechanical systems respond to a given stimulus in a predicted way, usually in detail and under different circumstances. A mechanical system may be complex like an automobile, but it does not show emergent behavior. Adaptive systems respond to different stimuli in different and unpredictable ways and are interconnected with the actions of other parts of a system. Many human systems, including health systems, are complex and adaptive. Health outcomes are not merely a product of a set of physical inputs, human resources, organizational structure, and managerial processes. Complex adaptive systems have the following key characteristics. Plesk, 2001. Adaptable elements, which means that they can learn and change themselves. In mechanical systems, change is imposed, whereas under adaptive systems, change can happen from within. Context. Systems exist within systems, and this context matters because one part of a system affects another. In health systems, changing the financing system may change availability and performance of health workforce, the use of other inputs, and the relationship with patients. In adaptive systems, optimizing only one part of the system may lead to poor overall system performance. In a hospital, for example, reducing the length of stay of patients in one ward may lead to queuing and readmission in other parts of the hospital, compromising overall quality or cost. Inherent order. Systems can be orderly even if there is no central control, often because they're self-organized. Health systems are self-organizing. Different types of provider organizations, associations, and behaviors emerge continually, either formally or informally. Not predictable in detail. Changes are non-linear or easily predictable. For example, a large health program may have little impact, but a rumor. Not predictable in detail. Changes are non-linear or easily predictable. For example, a large health program may have little impact, but a rumor may spark a strike or a riot at a clinic. Forecasting and modeling in health systems can be done to predict effects on health and poverty, but they are not predictable in detail because the elements and relationships are changeable and non-linear, often in creative ways. The only way to know what complex adaptive system will do is to observe them. Our changing world. So, epidemiologic, demographic, economic. Under epidemiologic, disease, infective, communicable to chronic, non-communicable. Recurring epidemic/pandemic of new and re-emerging infectious diseases. Under demographic, you have increasing population, you have younger to older population, and then you have rural to urban. Under economic, you have developing to developed economies. Then you have modern technologies lead to increasing exposure to environmental risk factors, example, air pollution. Then behavioral, still under our changing world. Under behavioral, you have changing lifestyle. There's faulty diet, alcohol, sedentary lifestyle, obesity, stress. Under our changing world, you still have healthcare systems. Under healthcare systems, you have centralized to decentralized. You have cost containment. Then under our changing world, you have political. Under political, you have control to free market economies. Context and dynamics in today's healthcare. Stakeholders' expectations. Under stakeholders' expectations, you have 1. Accountability. 2. Better results. 3. Higher quality. 4. Greater efficiency. 5. Greatest number of people served. 6. Equity. 7. Affordability. 8. Coverage. Under context and dynamics, you have 1. Health reforms. 2. Decentralization. 3. Increasing costs. 4. Decreasing resources. 5. Changing demand. 6. Increasing poverty. 7. Technical innovation. 8. Multiple initiatives. So in the middle of between stakeholders' expectations and context and dynamics, you have health service organizations. Shocks and disruptors. 1. Epidemics/pandemics. 2. Natural disasters. 3. Armed conflicts. 4. Climate change. 5. Financial crisis. 6. Restiveness. 7. Political instability. 8. Migration. 9. Chronic challenges. Practical implications of viewing health systems as complex, adaptive systems. What are the practical implications of viewing health systems as complex, adaptive rather than mechanical systems? 1. Can learn and change themselves. 2. One part of a system affects another. 3. Changes are non-linear or easily predictable. 4. Detailed plans and blueprints are less meaningful. Practical implications of viewing health systems as complex, adaptive systems. It does mean the following. 1. Understand the context. Look for connections between the parts, e.g. between programs, between demand and supply across sectors, anticipating downstream consequences and identifying upstream points of leverage. 2. Focus on simple rules to produce complex outcomes. Balance 3 types of rules at 1. Set direction, e.g. leadership and vision. 2. Set prohibitions, e.g. regulations and boundary setting. 3. Provide permission, e.g. setting incentives or providing resources. Health System Strengthening/Reform, HSR. HSS is an array of initiatives that improves one or more of the function of the health systems and that leads to better health through improvement in access, coverage, quality, or efficiency. WHO. HSR is an ongoing process of sustained, purposeful, and strategic change in policy and institutional arrangement in the health sector designed to improve the performance of the health sector and ultimately the health status of the population. Endpoints in HSS and HSR. 1. Universal health coverage. Unrestricted access to quality and effective health services. 2. Resilient health system. Ability of the health system to absorb disturbances and respond to current and emerging threats. 3. Universal health security, which comprises 1. Individual health security entails protection against risk through improved knowledge and social protection. 2. Collective health security considers reducing the vulnerability of societies to health threats that spread across national borders. We strive to strengthen our local systems so we can achieve universal health coverage, health security, and a resilient health system. Still, as part of goals of HHS and HSR, you have universal health coverage, unrestricted access to quality and effective health services. I think this is just a repetition. This 448 and 449 are just repetitions. Okay, so that's it. So you have a schema here. You can look at it, page 450. Strengthening health security and health systems. Key considerations in HSS. Scope. Include all building blocks covering local health needs. Scale. National and across levels of the system. Sustainability. Sustained over time and tackle systemic problems. Effects. Improved health outcomes, quality, equity, financial risk protection, responsiveness. Key areas of health sector reforms. WHO. 1. Reducing exclusion and social disparities in health, universal coverage reforms. 2. Organizing health services around people's needs and expectations, service delivery reforms. 3. Integrating health into all sectors, public policy reforms. 4. Pursuing collaborative models of policy dialogue, leadership reforms. And 5. Increasing stakeholder participation. Universal coverage. This will ensure that health systems contribute to equity, social justice, and exclusion by moving towards universal access and social health protection. Issues with access. Geographic, social, organizational, financial range of services. These are defined by availability, accessibility, accommodation, affordability, acceptability. Service delivery reform. Reorganizing health services around people's needs and expectations to make them socially relevant and more responsive to the changing world while producing better outcomes. Issues. Fragmentation, poor linkages, motivation. Public policy reforms aimed at securing healthier communities by integrating public health actions with primary care, by pursuing public policies across sectors, and by strengthening national and transnational public health interventions. Leadership reforms. This will tend towards replacing disproportionate reliance on command and control on one hand, and laissez-faire disengagement of the state on the other hand, by the inclusive, participatory, negotiation-based leadership indicated by the complexity of contemporary health systems. Stakeholder management is crucial. Okay, so all these are the stakeholders: multilateral and bilateral agencies, government, federal, state and LGA, academic and research institutions, health professionals, groups and institutions, consumers, patients and associations, NGOs, private sector, local and international DPs, media. Monitoring system strengthening. Monitoring and evaluation of health systems reform / strengthening a general framework. Okay, this is page 458. We need to look at this schema. Inputs and processes, output, outcomes, impact, indicator domains. Under inputs and processes, you have governance, financing, infrastructure / ICT, health workforce, supply chain, information. Under outputs, you have intervention, access and services readiness, intervention, quality, safety and efficiency. Under outcome, coverage of interventions, prevalence, risk, behavior and factors. Under impact, improved health outcomes and equity, social and financial risk protection, responsiveness. Data sources. Okay, we just look at it. Administrative sources, facility assessments, population-based surveys. Okay, so page 458. National health interventions, policy, strategies, plans, actions in the Fourth Republic. Leader, era, interventions, date. Leader, Olusegun Obasanjo. Era, 29th May 1999 to 29th May 2007. Interventions: establishment of National Health Insurance Scheme NHIS 1999, establishment of National Agency for the Control of AIDS NACA 2000, establishment of the World Health System WORD Health System WHS, and launch of World Minimum Health Package WMHCP 2001. First revision of National Health Policy NHP 2004, Health Sector Reform Program HSRP 2004, launch of the Formal Sector Program of NHIS 2005, National Health Research Ethics Committee 2005, merger of the National Program on Immunization NPI with the National Primary Healthcare Development Agency NPHCDA 2007. Umaru Yar'Adua as the next leader. 29th May era, 29 May 2007 to 5th May 2010. No interventions under Yar'Adua. Okay, so the next leader, Goodluck Jonathan, era 6th May 2010 to 29th May 2015. Interventions: launch of the National Strategic Health Development Plan NHSDP1 2010. Establishment of Nigeria Center for Disease Control NCDC 2011, Primary Healthcare Under One Roof PHCUOR 2011, Nigerian State Health Investment Project NSHIP 2011, National Health Act NH Act 2014, Decentralization of NHIS to States SSHIS 2015, Save 1 Million Lives Program for Results SOML P4R 2015. Muhammadu Buhari, that's the next leader, era 29th May 2015 to 19th May 2023. Interventions: second revision of the National Health Policy NHP 2016, National Strategic Health Development Plan 2 NHSDP 2 2018, Basic Healthcare Provision Fund BHCPF 2018, launch of the Community Health Influencer and Promoters Program CHIPS 2018, Health Insurance Under One Roof HIUOR 2020, National Health Insurance Authority 2022. Intended impact of national interventions across health system building blocks. This is page 461. So you have intervention, you have potential impact of intervention on SBBs, LG, HF, WF, PI, IRSD. So you can look at it, page 461. Health Sector Strategic Blueprint 2023 to 2027. 2027. Our goal is to save lives, reduce both physical and financial pain, and produce health for all Nigerians. Outcome we want to achieve include improvement in mortality and morbidity rates, drop in out-of-pocket expenditure by patients, and reduction in difference in health outcomes within different income quartiles. Effective governance. Under effective governance, you have strengthened oversight and effective implementation of National Health Act, increased accountability to and participation of relevant stakeholders and Nigerian citizens, strengthen regulatory capacity to foster the highest standards of service provision, improve cross-functional coordination and and effective partnerships to drive delivery. Under efficient, equitable, and quality health system, you have drive health promotion in a multi-sectoral way, including intersectorality and with education, environment, wash, and nutrition, strengthen prevention through primary health care and community health care, improve quality of care and service delivery, access across public brackets, secondary, tertiary, and quaternary, and private health care providers, improve equity and affordability of quality care for patients, expand insurance, revitalize the end-to-end production to retention healthcare workers pipeline. Next point, unlocking value chains. Under that, you have promote clinical research and development. 2, stimulate local production of health products. 3, shape markets to ensure sustainable local demand. 4, strengthen supply chains. Okay, so the final one is health security. Improve the ability to detect, prevent, and respond to public health threats, e.g. cholera, Lassa. Then build climate resiliency for health system in collaboration with all other sectors. So then we have data and digitization, financing, then culture and talent within MDAs. So page 462. 21 priority initiatives underpinned for HSSB blueprint. 70 initiatives developed and 20 prioritized. Plans, effective governance, efficient, equitable, and quality health system, unlocking value chain, health security, enablers, data and organization, financing, culture, and talents within MDAs. Number 1, strengthen the NCH as a coordinating and accountability mechanism across the health system. 2, a sector-wide action plan. So I think you need to look at all these. There are 21 priority initiatives underpinned for HSSB blueprint. Strengthen, I'll look at them. I'll read them one after the other.